So my name is Dominique Jones, and I work for the Minnesota Department of Human Services. I'm a clinical treatment policy manager in our behavioral health division, and I'm here today to talk about the Minnesota crisis delivery system for mental health services. So our mental health crisis delivery system in Minnesota consists of mobile mental health crisis services, residential crisis stabilization for adults, and crisis text line. So with our mobile mental health crisis services, Minnesotans have 24/7 access to crisis services across all 87 counties in our state. This consists of 33 teams that provide services to both children and adults, and 4 of those teams are tribally specific teams. Typically, we contract directly with counties and tribes to provide services, and sometimes they provide them directly, and at other times they subcontract them out to community providers. With regard to our residential crisis stabilization service, this is a service that provides an average of up to a 10-day stay, and it's specifically for adults. We have 22 programs across the state that cross 9 counties and have approximately 122 crisis beds available. And finally, our final component of our mental health crisis service in Minnesota is our crisis text line service. And this provides individuals with 24/7 access to a crisis counselor via text message. And so individuals in Minnesota are able to text the letters MN to 741-741, and that allows them to access a responder. We also have regional suicide prevention coordinators located throughout the state that promote the service and kind of provide an awareness about crisis text line, how to access it. They also do presentations for social services, for schools, just throughout the state, and also offer some training such as QPR, assist, or postvention trainings to provide information around suicide prevention. They coordinate with our Minnesota Department of Health, who is our state suicide prevention authority, around suicide death data to make adjustments around where outreach needs to happen related to crisis text line and the reach for that service. With regard to our mobile crisis delivery system, it consists of a phone screening, a face-to-face assessment, therapeutic intervention, short-term crisis planning, and then finally connecting individuals to ongoing services. And our crisis services can be provided by a mental health professional, a mental health practitioner, and a certified peer specialist under the supervision of a mental health professional. So the phone risk assessment is the first component of the crisis service when an individual contacts our crisis teams in Minnesota. Each mobile crisis team is required to submit a decision tree to the department for approval, for review and approval. And once that decision tree is approved, it's to be used to determine which steps should be taken when an individual contacts a crisis team. So for instance, they are expected to determine criteria that would meet imminent risk that would prompt them to notify 911 for an immediate response to a crisis call. Criteria to determine if a call is appropriate for resource and information and referral, criteria for phone support and in lieu of a face-to-face assessment, and then criteria for a face-to-face assessment. All crisis responders in the state of Minnesota are trained in verbal de-escalation, recognizing responding to risk assessment, responding to child and youth specific crises, co-occurring mental health, intellectual developmental disability, and traumatic brain injury that present in a crisis, in addition to trauma-informed and responding to culturally specific communities in crisis. So in Minnesota, there are some factors that can impact response times. While services are available 24/7, at times, the location of the individual can have an impact on the response time. whether a person is calling from our greater Minnesota or our metro area. So some of our teams in greater Minnesota, which is more of our rural areas of the state, have teams that serve multi-county regions. So you may have one team that serves a 10-county region, and they may be driving from one end of their catchment area to the other, might be anywhere from like 1 to 2 hours. And so that windshield time can impact response. In the metro area, while there's a shorter distance to drive, it's where some of our more saturated counties are located. And so the demand in response and the amount of traffic and the time it might take to get to a response might impact response time. Additionally, the availability of responders sometimes can impact our response time as well. And that just has to do with the capacity versus demand. And each of our teams are structured differently. The number of on-call versus staff who are available, mental health professionals or practitioners that are available at a time to respond. And so that can vary. Teams try to staff according to peak times to make sure that there's as much coverage as possible to meet the demand. And then finally, safety factors. There may be some cases when a call comes in where the mobile team might assess that 2 responders may be more appropriate to respond for safety reasons as opposed to 1. And so that can impact response times. Additionally, we have taken some steps to try to expand response to mobile crisis calls within our state. And some of those have been legislative changes that have been implemented to help with that. So within the last few years, we've had some statutory changes, and I'll highlight a few of them. One specific change was a change to the definition of health officer in our 253B statute that would allow a change in definition to include a mental health professional on a crisis team to be included as a health officer. And so prior to this change, mental health professionals on crisis teams were not able to write transportation holds. And now with this statutory change, they're able to. And so that kind of helps with response. Clarifying language was also added last session to allow for crisis teams to respond to the ED or to urgent care when the legislative changes that we've implemented within the state over the past few years to provide some clarifying language and to just overall try to work towards increasing and expanding the response of our mobile teams. So one of those changes was a change to the definition of health officer in statute, and that change allowed for a mental health professional on a crisis team to be included in the definition of a health officer. So prior to this change, mental health professionals on crisis teams were not allowed to write transportation holds. This change allowed for that to happen and to help if a crisis team is completing an assessment and an individual needs to be transported to be further evaluated at the ED. There were some other clarifying language changes just to provide more clarification that mobile crisis teams can respond to the ED or urgent care when requested by a health team, and that they can respond when requested by a peace officer. So some of these were just statutory language changes to provide clarification, and we are newly into the implementation of some of those changes, and so we hope to see more expansive responses. So in Minnesota, our mobile crisis services are funded in multiple ways. So there are some components of the service that are funded through Medicaid, and then there are other components that are funded through grant dollars. So the crisis assessment and intervention and state and crisis stabilization, both community and residential, are all funded through MA. The other components of our services are funded through state grant dollars and through county levy dollars. And so we have a base amount of state grant funds that we do a competitive application process for counties and tribes to apply for in order to cover the following services. So benefit and service navigators to help people get signed up with insurance. Also for uninsured and underinsured individuals, in Minnesota, our crisis services are not covered by most commercial insurance. They aren't currently recognizing it as a emergency service. And so having some grant funds to cover the costs for individuals who would not be covered under their private insurance, this would allow for them to fall in that underinsured category, or for those who are uninsured to be able to access this service. Additionally, mobile crisis teams can use grant funds to pre-purchase psychiatry slots to allow for individuals who are experiencing a crisis to have rapid access to a prescriber. So whereas those services may not be available, those psychiatry services may not be available for, months, they could get a same day or same week appointment to see a prescriber to address their crisis. Additionally, the grant funds can be used to cover emergency medication and the phone screening part of the crisis services. So counties are also responsible for contributing to their crisis services, and that varies across the state. We're still currently working on figuring out what that looks like from county to county and throughout the state as we work towards sustainability. And I'll just share a little bit of data, just some quick data about our crisis services for the calendar year of 2020. We're still working on cleaning up our 2021 data, so wasn't able to provide that at this time. But in 2020, there were 16,117 mobile crisis episodes that occurred in Minnesota. And of those episodes, when we look at face-to-face assessments, from the time of referral to the actual face-to-face assessment, about 84% of those occurred within less than 2 hours of the time of the call and assessment place. And then finally, the top 3 primary reasons for intervention in 2020, the top 3 reasons people reached out to the crisis team or had a crisis assessment. The top reason was suicidal ideation. Second reason was depression. And the third was anxiety and panic. So before I mentioned that we have a partnership with our crisis text line to provide our suicide text messaging platform for the state. And so the Department of Human Services in Minnesota developed a partnership with Crisis Text Line in 2018 to be able to provide this service. And so as I mentioned earlier, individuals can text MN to 741-741, and it provides data for our state around who's accessing the service and for what reasons, and kind of gives us demographic information. We work with our Department of Health around developing a data dashboard. And so this data is helpful for them in their suicide prevention efforts. We also have regional coordination contracts throughout the state. We had an RFP that went out in 2018, and we executed contracts for our 7. So we have 7 northern tribal nations within our state. And one of our tribal nations, our Fond du Lac Band, is our suicide regional coordinator for the crisis text line. And we have our 30 northern counties that Carlton County is our suicide regional coordinator for. And then finally, the 57 remaining counties and the 4 Dakota tribal nations in the southern portion of our state are contracted out through Canvas Health. So these suicide regional coordinators, as I mentioned before, really work to coordinate with our Department of Health around suicide death data to ensure that if there are increases in trends in our suicide death data, that they're really reaching out to those populations and those demographics to get information out around this service, to engage in suicide prevention activities and very specific evidence-based practice trainings. And then finally, we are working on the implementation of 988 as most other states are. And so our Department of Health is leading the effort, and our Department of Human Services is partnering with them on those efforts. I'll just provide a brief update about our plan and our goals for 988 implementation in the state of Minnesota. So we currently have 4 in-state Lifeline centers. And right now they are providing coordination and collaboration. We have the Department of Health and the Department of Human Services role is to kind of coordinate and collaborate between the state and the Lifeline centers. And we also have collaboration across state agencies, as I mentioned, due to our Department of Health being our state suicide prevention authority and our Department of Human Services being our treatment side of the service. We had a 988 coalition that met over the last year to identify, and that just consisted of different parts of our system to establish and develop goals. So some of our immediate goals in this ranges from October 21st to June 2023 is to scale up our in-state capacity to provide 988 services. And so we have done that. We are at up to 4 call centers, which prior to the implementation of 988, we had 2. And so now we have 4 call centers that are working to answer the in-state answer rate at full capacity. Our long-term goal from January 2022 and beyond is to determine how 988 is going to interface with our existing crisis services. And so that will be ongoing collaboration with our external stakeholders, with our crisis providers, with our Department of Health and our Department of Human Services to figure out what that's going to look like. And our end goal is to really have a coordinated and collaborative effort across all entities that are involved in crisis care. And so as we move into our 988 planning, we're going to continue to assess and evaluate where our current crisis system is and what changes may happen as a result of that implementation. So thank you for your time today, and please let me know if you have any questions.